started today at 12:05. So welcome. Appreciate everyone who's joining us today. Quick question for you, Brenda. Are you recording the meeting for us as well? Let's see. I don't think she's in yet. All right, here we go. All right, welcome everyone. Welcome to today's October 1st Department of Public Health Project Echo session. Where we'll talk about prostate cancer education and awareness. So thank you for spending this hour with us. All right, welcome everyone. Just a reminder that if you have any questions, comments, or resources that you want to share today, as we talk about prostate cancer, some of you may have some really great things going on at your organization and you want to share that. So put that in the chat for us. You can do that at any time during the meeting and we will, address it or ask any questions after the speaker presents. Let's see if Dr. Poole's here. Let's see, he's coming.
Hey, Sonia, I'm here.
Hey, Dr. Poole. Great. You are, okay, got it. Just as another quick reminder, and I'll repeat this again, and as I'm turning off, silencing my phones, if you all would do the same for us. I have been in meetings where I had my phone, didn't have it on mute, but when I came off of mute to speak during the conversation or online, my phone started ringing. It's like, okay, great. So it wouldn't hurt to go ahead and silence those if you could, even though we were on mute during most of the meeting. Dr. Poole, we are going to get started at 12:05. Just, I don't know if you've heard me say earlier, just to give everyone a little more time to sign on today. And we'll get started as soon as that time hits. If anyone wants to turn your camera on and show us those smiling faces, that would be great as well, but understood. I like seeing the cameras on because it gives us that close family feel. If possible, you could do that, but again, understood if you can't or are unable to do that. Sometimes it's not always possible. Thank you, Lisa. I have heard of Zero Cancer. I might follow up with you on that because I've had questions. Looks like some great stuff that they're doing on that. A retreat. Okay. Awesome. Lisa, would you know if this is an online opportunity? I know our department staff right now, we're unable to travel, but we'll talk more about that. If it's possible that we could participate virtually, that would be great too. So, all right, Jordan, I have 12:05 on my end. Okay, thank you, Brenda. Traveling and unable to turn your camera on. I totally understand. All right, Jordan, have we hit the start button? We're ready to go. Okay, I'm going to start the meeting. Let's roll, you all. All right, again, welcome to the Department of Public Health Cancer Section's Prostate Cancer uh, Project ECHO October session and October 1st session, and we are delighted that you can join us today. I know that everyone's time uh, is limited and your schedules are busy, so thank you all for making the time to join us, and you won't be disappointed. Today we have some incredible information to share on prostate cancer from a representative from several aspects, but Dr. Anthony Poole is part of our South Carolina Prostate Cancer Work Group with our Cancer Control Advisory Committee. And he, with some of his colleagues and staff here at the department, have done an excellent job on prostate cancer and some awareness pieces and resources that are underway. And Dr. Poole was able to step up today and speak to us today on prostate cancer. And without further ado, I just want to give a quick introduction on some of the many things that Dr. Poole does. So let me just go ahead and start with his bio. It reads that Anthony Poole serves as the Senior System Director for Quality Assessment and Performance Improvement at the Medical University of South Carolina in Charleston, South Carolina. In this role, he leads a team of quality and safety managers to implement quality initiatives across all clinical and non-clinical services for a 16 hospital health system across the state of South Carolina. In addition to his administrative duties, Dr. Poole also practices clinically as a physician associate in family medicine. Prior to transitioning to MUSC, he served as the Chief Clinical and Quality Officer, a large federally qualified health center serving the Low Country region of South Carolina. In that role, he oversaw all aspects of the quality improvement and risk management programs, as well as clinical, quality, and outreach operations. Dr. Poole was recognized as the South Carolina Provider of the Year in 2020 by the South Carolina Primary Healthcare Association and one of Charleston's 40 under 40 professionals in 2020. Not surprised by that at all. He currently serves in leadership positions on a variety of community boards, including, as I mentioned earlier, the South Carolina Cancer Alliance. He is a co-chair of that committee, again, which serves as liaisons and advisors for us here at the Department of Public Health. And he is president of the board of directors for the American Heart Association's Low Country chapter in South Carolina. He is passionate about health equity and increasing access to quality health care services for all people. And if I could add a personal note to that, Dr. Poole, again, serving as an advisor and a leader for us here in cancer at the Department of Public Health, definitely a passionate individual, hardworking, and we're really glad to be under his leadership, and especially glad to have him speak today. So I am going to hand the mic over to you, Dr. Poole, but before I do, would you like for me to advance your slides when I share the screen, or do you want to share your screen and advance your own slides?
I tell you what, we can go, if you don't mind doing it, that would be helpful, as long as you're fine with me saying next slide, back and forth, and all that stuff. Excellent, thank you. Well, thank you so much for the introduction, Sonia. I apologize, I probably sent you the long bio, and so everybody had to sit through that. But again, you guys, I'm Anthony Poole. I am at the Medical University of South Carolina. And I want to give a big shout out before we get started to Dr. Stone and Dr. Wallen, who put this presentation together. It's been shared with individuals across the state in our FQHC setting. The CMOs have got a chance to see this, and I was asked to present it today. So thank you to these two physicians who have put a lot of work into this. And a little bit of background, even before we get into the meat of this, Sonia did mention, we do have a subcommittee to our state level cancer control advisory committee through the Department of Public Health. And about 2 years ago, we we got the permission from the larger committee to launch a prostate cancer focused subcommittee. And so over the past 2 years, the work of this committee has really been focused on three aims. So patient and community education, provider education, not only to our primary care practices, but other specialties, including urology, and then patient navigation. So navigation to screening, navigation to treatment, and those things. So this is a byproduct of that, coming together and saying, how can we educate our population? How can we educate primary care providers? And so I know we have a vast audience here today that extends into several of those buckets. So I'm just excited to share with you. Jumping right in, I will also clarify I'm a primary care provider. So, Dr. Stone and Dr. Wallen are urologists, and I did reach out to them for some background on a few of these studies and some of the things we'll be talking about. So really would like to talk to you just on a peer-to-peer level. These are things that I'm seeing in my clinic. I practice here at MUSC, and then with the work I do on the quality side. So Sonia, if you want to go ahead and go to the next slide. So the goals and learning objectives, what we want to talk about today is review some of the changing guidelines on PSA screenings. We know there's a lot of confusion around that over the last 15 years. And then look at some of the recent trends in prostate cancer, just epidemiology. There's two studies that I'm going to highlight that really tell the story behind how the guidelines came into place, why they are where they are today, and frankly, why they are so freaking confusing. And then talk about a few innovations that have reduced harms of diagnosis and treatment, and then advocate, as we're all here, to advocate for screening as a method to reduce the disparities that we see in prostate cancer. So next slide. Looking at the state of South Carolina. So this is, why are we worried about this? When you look at cancer deaths in South Carolina, you see several counties highlighted here. So you've got Greenwood, Fairfield, Marlborough County. You see some darker orange there in the Midlands with Richland, Sumter, and Newberry counties. They're coming down toward the lower part of the state. We see, Hampton and Colleton counties, and then Williamsburg County just a little bit above Berkeley County and Georgetown County there. So really highlight this to show that this is impacting our entire state. The counties that are in white are ones that we did not have enough data on. Doesn't mean they're not impacted as well. I can almost tell you for a fact that I know some of these counties in white are some that, if it tracks with other cancer statistics, we see a lot of high cancer incidence, prevalence, and sadly mortality in those counties as well. So if you look to your right, we look at a graph that we like to see, right? This is a good thing. We see decreasing rates of cancer deaths year to year when it comes to prostate. So why are we even talking about this? Hey, it looks really good. We were at 40-something%. Now we're down to 20%. Like, let's wash our hands. We've done a good job. Wrong. No, one death, in my opinion, and I'm sure I'm preaching to the choir here, but one death is too many. So while we're seeing decreasing rates, that's a great thing. But think about what's happened over the course of these years. There's been a lot more advocacy about cancer as a whole. There's been a lot more screening efforts. And so it's one of those things where, you say a rising tide rate lifts all boats. Well, if you overlay this graph with breast cancer and cervical cancer and all the other types, we see these decreasing rates across the United States, as well in South Carolina. But when we compare our state compared to other states in the country, we still see very, very high rates. And so that's why we all still have a job to do in getting the word out about this. That's why we're here today. So I just want to thank you so much for your time. As we jump into it, we can get on the next slide. So the next slide really highlights our why here. We look at cancer rate deaths by race and ethnicity, and no, this is not a health equity lecture, but when you look at the data, we see that depending on the demographic box that individuals fall in, we see that certain demographics are hit a lot harder. If you do the math on that, we see that Black men in South Carolina are 2.3 times more likely to die, not be diagnosed, but to die from prostate cancer than white counterparts. So again, we've got work to do across the board, and these efforts aren't focused specifically on Black males, but we want to make sure that we are getting the word out, screening all patients, and really the why we're all here and why we're doing this presentation is we want to continue to see that downward trend in prostate cancer deaths, and we're going to do that by closing this gap. So closing this gap that exists amongst our portions of the population that have the biggest gap there. And so focusing that with the previous slide, the way we're going to do that is by really targeting specific populations and making sure that we are increasing our screening rates. Early detection saves lives. I know my good friend, Dr. Marvella Ford, that is her theme. And so we need to tattoo that. If I could have a background going right here, it would say early detection saves lives. So next slide. I think this is just a reiteration of the goals that I talked about a minute ago. So you can hop to the next one. So this is a busy slide, but it looks at prostate cancer compared to other really important types of cancer, lung, colorectal, urinary bladder. As you can see, prostate's up at the top. So we see that prostate cancer consistently is the higher, we see higher rates of prostate cancer compared to our other sites. Why does prostate cancer have such a squiggly line compared to the others? So I'm gonna break this down a little bit. Bear with me here, kind of looking at notes. So if you look at from 1985 to early 1990s, right? You see a big time increase in prostate cancer. Click one more time. Sorry, I didn't realize this pops in. So in 1990, around 1990, PSA testing is introduced. So, well, why do we continue to see an increase? So we were already seeing an increase, and then PSA testing was widely introduced. And so the reason for that between 1990 and 93, 94 is that as screening increased, we see there were a lot of undiagnosed cases. So we know that rates were already going up for those men who weren't going in, getting screening. Once PSA testing got introduced, and there was a lot more public word getting out about it, we saw that spike big time. And then around 95, you can click to the next one, but around 95, we see things start to level out a little bit. We see kind of some ups and downs and everything up until 2008, where we see U.S. Preventive Service Task Force putting some barriers around screening and say, hey, we're not just going to screen everybody. We're going to put some age restrictions on there. Go to the next one. Click one more time. And then one of the studies that we're going to talk about, the results of the PLICO study came out in 2008, 2009, and we saw further restrictions. If you click one more time, you see the U.S. Preventive Task Force said, based on this data, we really need to restrict things even more. And so we, continue to see things go down. Around 2016, and I'm going to highlight that here in just a second, some more data came out where we looked at that PLICO trial and said, hey, there were some things in there that we should not have been basing our recommendations off of. And so a lot of confusion ensued. U.S. Preventive Service Task Force, and I can't speak on behalf of them, I can just say based on the data that we see, they started to lower the grade there. So they do agree that more men need to be screened for prostate cancer. And one of the reasons we talk about this so much in South Carolina is because we feel strongly that downgrading to the D did so much damage to our state. Even upgrading it to a C still has caused a lot of confusion amongst my colleagues as primary care providers. And so we want to make sure we're giving some background on that. We do see, and we can go ahead and go to the next slide, but toward the end of that, we're seeing an upward trend. We see that it's starting to rise again, due in part to increasing rates of advanced and more metastatic cases. So what these slides are, for those who are not providers and don't understand some of this this verbiage here, when we talk about our SEER staging, this is basically looking at advanced cancer stages, right? So SEER stages is like the most basic form of kind of how we classify things. We do it for a lot of our cancers. We talk about carcinoma in situ, localized cancer, where it's just localized to the prostate. We look at regional, where it starts to get outside the prostate. And then we start talking about distant cases. So this graph is showing distant cases here. And Sonia, I apologize, I'm gonna have you flip back and forth just a little bit. So if you go back to, if you look at the timeline here, where we start to see an uptick around the 2009 range, is where we see when the U.S. Preventive Service Task Force started putting some of these restrictions in place. So going back to the next slide. And sorry, having you click it, we'll go back and forth a couple times. But as we see that, so we were seeing decreasing rates, right? So what makes sense of this? As I was looking at this, and I talked to Dr. Stone a little bit and tried to, based on this as a provider from a public health standpoint, I can understand it. But what happens is we were seeing decreasing early stages, right? Decreasing early stages. And as things started to shrink down, we were testing less men, we started seeing more advanced cases. So what happened was we saw there was a lag time there from when we stopped screening so many men, then you see a lag, and then you see an uptick in more advanced cases. One of the things that stands out to me on this slide is you see the two lines, right? You see the yellow line at the top, which is higher rates. We see that with our older men over age 75, and then our younger males age 45 to 74. Well, that rate for the younger men stays kind of flat. It is ticking up a little bit, but it stays kind of flat compared to our older one. Well, what have we been saying? Early detection saves lives, right? So if we are screening these men, or what was happening is we stopped screening men over age 75. So by the time they went to their doctor because they were having urinary symptoms or, anything else, they were already at these advanced stages by the time they were diagnosed, which as you'll see when we start talking about treatment options and stuff, do require more advanced testing. So bottom line again, these trends go hand in hand with what we saw on the previous slide. As we decreased our screening rates, we started seeing higher and higher rates of metastatic and more advanced prostate cancer. Next slide. So this is a study from New England Journal of Medicine by Gil Welch, who is an opinion leader on cancer screenings across the board, and really went to show the impact of widespread PSA testing. And I won't make Sonia go all the way back to that slide, but back on slide 5, when we see where PSA testing was introduced in late 80s, early 90s, right there, we started to see a dramatic decrease in the incidence of metastatic disease. Again, and if we could put all these slides, these graphs side by side, you'd start to see that as we screen more men, we saw lower rates of more metastatic disease, which is what I highlighted on the previous slide there. Next. So I think that's just, highlighting what I just said. Next slide. So obviously we want our decisions to be evidence-based, right? We know what we feel, we know what we're seeing subjectively in our communities. We know that, everybody, I would be willing to say everybody on this call probably knows one or more men who've been impacted by prostate cancer. So, but what does the data show? As clinicians, we don't go based off what we see and what we feel. We go based off of what the data and the guidelines say. So what are they basing the U.S. Preventive Service Task Force, what are they basing their guidelines off of? There's 2 big studies. So there's a European study, and then there's the PLICO trial. And so we'll dig into each one of those just a little bit. The next slide. Talk about the European study. So there was a study done that across 8 European countries. There was over 160,000 men, younger men, aged 55 to 69. So we started screening earlier. Before it, we weren't catching men in their 70s. We wanted to catch screening earlier than that. And so we wanted to look at that and follow up with these men at 9 years, 11 years, 13 years, and 16 years, just to show the impact on early screening and how that impacts mortality rates and things. If you go to the next slide. So busy, a lot of numbers when it gets to statistics up at the top, but the 2 things that I want to kind of draw everyone's attention to are the last 2 lines, that NNI and NND. So that NNI, sometimes that's referred to as NNS, so the number needed to screen. So that's how many patients do you have to screen in order to catch a case of prostate cancer. And then that next one, NND, is how many cases do you have to diagnose of prostate cancer in order to save 1 life. So that makes sense there. And as we go along, what we see is that 9 years, 11 years, 13, the further along you got, so you catch him in his mid-50s, you screen him at that 16-year mark, it only takes 18 cases to save 1 life. And so a lot of times we look at, are we over-screening? Are we over-testing? And while, the number of 570 screens in order to catch 1 case seems high, the next slide is going to show you how that compares to our other screening rates. You can go ahead and go, Sonia, to the next one. So when we talk about prostate cancer screening compared to mammography and colonoscopy, our other 2, we look at breast cancer screening rates and colon cancer screening rates. So when we talk about for screening for PSA testing in men, it takes 570 screens in order to catch 1. Seems like a lot, but if you think about mammography, which nobody right now, based on the fact that we've had so much advocacy for breast cancer, we have a whole month dedicated to breast cancer screening, everyone agrees that mammography is a good thing for our female patients because we're catching breast cancer early. Well, if you compare the numbers, you have to do, let's just talk about women in their 50s up to age 70, 1,500 or 1,100 mammograms in order to catch a case of breast cancer, right? Much higher rates. So this data, basically the European study showed, hey, we need to be screening men early and often. The earlier we screen, the more likely we're going to catch cases of cancer, and the more likely we are to prevent deaths there. And the other thing there with colonoscopy, the numbers are a lot closer. So with colonoscopies, 455 screenings to catch a case of colon cancer. Look at the grades there. So you look at grade A for a screening, grade B for a screening for mammography. And again, if we go back to slide 5, we know that we're currently at a grade C when it comes to prostate cancer screening. So even though the data shows it takes less screens to catch a case of cancer, it's still recommended to do mammography over prostate cancer screening. And please don't misinterpret what I'm saying. I'm not saying we shouldn't be doing mammography. I could do a whole nother presentation on breast cancer screening, but we'll save that for another lecture. Next slide. This is going over the PLICO stuff. So getting into the next trial, which was that PLICO study. It was a U.S. study in 2009, and they did intervention PSA for 6 years, men aged 55 to 74. If you go to the next slide. And this is what resulted in the U.S. Preventive Service Task Force making their recommendation. If we went back to slide 5, you'll see that when the U.S. Preventive Task Force set the age range at 74, no screening over age 74, rates were going down. And then the study came out here in 2009. And if you look at these, and we don't have to get super statistic, but in B, when we talk about prostate cancer death, it's interesting because there's not a big difference between the screening arm and the control arm. So what they did in 2009, they took this to mean, hey, it doesn't really matter if you're screened or not screened. We see the death rates remaining the same, and they're actually overlapping in the first few years, even going out to year 10. There's only a small difference in those. So, back in 2009, and this is when I graduated from PA school and started practicing, in 2009, the guideline was, hey, screen everybody over age 40. That's what I learned in school. That's what I started doing my first few years out of practice. Well, evidence based on this trial was showing that there's not that much difference between those who are screened and those who are not screened, unfortunately. If you go to the next slide, though, you will see our difference here. And over to the side, what they found is they dug into this and reevaluated this in 2016. They found that nearly 90% of the men in the control arm had actually undergone PSA testing. So in this study, it wasn't not screened versus screened. It was not screening like annually, but they didn't look and say, well, have these men ever been screened? So the reason, if you go back one slide real quick, Sonia, sorry, I'm making you work for it today. The reason for that, the close data in B, and the reason they track so closely, even in A, like the incidence of cases there, is because the data was skewed, right? The data in the control arm was mixed in with 90% of these men actually receiving PSA screenings stuff. So that data didn't come out till 2016. And if you remember back to slide 5 in that graph, that's when the U.S. Preventive Task Force goes, oh, okay, you can go ahead and go forward to the next one. We'll talk about it too. But that's when the U.S. Preventive Task Force went, oh, okay, well, maybe there is something there. And because we see that sample does not truly represent screening versus no screen there. Unfortunately, it just went to a C, so we're not seeing as much of an impact as we would like to have. Next slide. So when we look at both of these studies, the European study and the U.S. study here, we know that the European study, large trial, it showed significant reduction in prostate cancer screening mortality and later stages things if we screen men early and often. It supported that data that, nothing there to show otherwise. We talk about the PLICO study, the U.S. study, we see there was contamination in that control arm, and that happened before all the conclusions. So all the guidelines that the U.S. Preventive Task Force was using to set these screening data was skewed. And so really we show that there was no big difference between organized or opportunistic. Organized means like being scheduled, screened on a schedule versus opportunistic when a man comes into my office complaining of urinary type symptoms, and then we do a screening when he otherwise had not been screened. The image there just showing, sadly, what's happening is because the data has been off and there's a lot of confusion, we're kind of throwing the baby out with the bathwater, if you will. And so what's happened now is because we've gone from over the course of just my career, from 2009 to today, in the last 16 years, there's been, hey, we should screen everybody, to, oh, we should stop screening at 74. Oh, we shouldn't screen at all because the PLICO trial says there's no advantage to screening versus not screening. Then they look at it again 9 years ago and say, oh, well, maybe there is some there. What should we set this thing at? And it's a C. So I guarantee we do a poll of, which we have done as part of this cancer subcommittee, prostate cancer subcommittee, a poll of primary care providers, even across just the state of South Carolina, and the understanding is all over the place. I've talked to colleagues and they say, well, I didn't think we were even screening men anymore unless they came in for it. So a lot of providers in this state are still doing opportunistic screening for prostate cancer there. And so if you take nothing away from today's presentation, just an understanding of why there's a lot of confusion around what should be done and who should and shouldn't be screened. And I tell people anytime I get a chance to talk about this, specifically for our African-American men, but anybody, if you're in that age range where you should be screened 55 to 70, even a little earlier, which we'll talk about some risk rates there, you do need to advocate because a lot of providers, unfortunately, are not aware of this backstory behind these trials that went into making these recommendations. Next slide. Going into the guidelines. So again, highlighting that they're mixed. So we talk about the U.S. Preventive Service Task Force, still a grade C for all the reasons that we just talked about. It's a grade D. They're still not recommending screening and testing for men over age 70 unless there's some specific circumstances. When we look at the American Urology Association, their recommendation is to begin at age 50 and screen through age 70 or age 69. So 50 to 70, you want to be screening every 2 to 4 years. It's a strong grade A recommendation, and they're basing this off of their knowledge and understanding now of the data that was being used to set these recommendations at the national level. So the recommendation there is to begin even earlier. If you're starting at age 40, if you're a Black male, if there's genetic germline mutations, or if you had genetic testing showing that you're at an increased risk, or if you've got a family history. So all more important, this is what we're tailoring a lot of our public health awareness and messaging to, is knowing your family history. You know, men don't like to talk about their health situations and stuff, but you've got to dig in. For my patients in their 40s, I say, you got to know what your dad, your uncle, your grandfather, you got to know what their prostate history was. And we can offer baseline. So across the board on that one, you know, it's recommended to offer baseline screening at age 45. National Cancer Control Network, their recommendations 45 to 75, so it is a little bit older. Again, every 2 to 4 years. And this is where we get into some of the results, right? So if the PSA screening in a younger male, if your PSA is less than 1, keep it every 2 to 4 years. If the PSA is over 1, it's recommended to do a little bit more often than the every 2 to 4 years there. And so again, every 1 to 2 years, if you're considered high risk. So what is high risk? Black, genetic mutations, you know, and there's a lot more information out about the importance of genetic testing. And I won't get super into that in this presentation, but I think for our communities in South Carolina, we need a lot more awareness of what genetic testing is. Sadly, we hear genetic testing and a lot of communities start thinking Tuskegee and all these other things that were happening in the 60s and 70s on certain populations. And we know that thankfully is not the case. When we look at genetic testing now, we're looking at, do you have genetic markers that show, compared to other national and international data, that you are at an increased risk? And goes without saying, family history, most important thing. They're looking at your family history. When it comes to the American Cancer Society, the ACS guidelines, there's still a lot of verbiage in there about shared decision-making, starting at age 50 for men that are at an average risk. So most men fall into this category. Age 45 if you're high risk, age 40 for the highest risk. What is highest risk? It's those things we just talked about, our Black males, genetic history, and family history. If I could add something to the slide, it would be in bright red letter saying Black males need to be screened for prostate cancer starting at age 40, based on the data that I've talked about. Will be 2.3 times more likely to die from prostate cancer. The graphs showing that early detection saves lives. We see lower mortality rates if we're catching things early. And by screening early and catching things early, we're not seeing that graph where we saw spikes in the metastatic and advanced cases of cancer. All right, next slide. You guys can see why providers get confused about this, because when you have 4 different organizations making guidelines, it does kind of make you go cross-eyed, right? You know, we don't know what the source of truth is, so we have to determine based on our best interpretation of the data, and so that's why we're focusing this stuff on these studies. There's another study here that was a UK study done showing men in that age range. It was 82,000, again, a large study showing treatment options, right? So we know now active monitoring and active surveillance is the most widely recommended form for early detection of prostate cancer. We'll go to the next slide and we'll start digging into some of the data there. The good news is, so looking at this slide, again, a bunch of numbers, some statistical things. If you look at table 2 on the left there, we talk about survival rates. We want to look at 15-year survival rates on patients, whether they're doing active monitoring, if they've gone through prostatectomy, removal of the prostate or partial of the prostate, or radiotherapy. And the good news is in that second column there, you see with active monitoring, with all three things, we're seeing really, really high rates of survival at 15 years, which is what we want to see. Very high rates, 98, 99% at 10 years, 96 or better, even with active monitoring of early onset prostate cancer. So the thing in this arm here, when you look over to the right, we're seeing more than 50% of the men who undergo active monitoring. What we're looking at is signs of it advancing. And then when it does advance, that's when we go on to more interventional types of treatment options there. Next slide. So a couple things on this one, again, kind of showing the differences in metastatic disease between active monitoring, prostatectomy, and radiotherapy. So again, we're not a statistics lecture here, but want to make sure that people see. If you click forward a few times, Sonia, I think there's some boxes that get highlighted in this one. Yep, still seeing very, very strong rates of survival with primary and secondary. You can go ahead and click to the next one. The biggest thing there at the bottom is that clinical progression. So with active monitoring, we see that active monitoring early on is more likely to save lives. Yes, we're going to see 50% of those cases go on to need some type of intervention. But again, if we're catching it early, if you look at that slide beforehand, we're seeing the mortality rates continuing to stay low. Sadly, if we're catching it later, then active monitoring is not an option. Then we go straight to surgical intervention or radiotherapy interventions there. Next. This slide. Sorry, you can hit the next one. Next slide, just kind of a document of risk benefits. So that's where a lot of, on the provider side, a lot of the education has been shown and on the risk benefit and the messaging that's trickled down over the last 16 years to providers because of a lot of this confusion and stuff. There has been like, what's the benefits? Do the benefits outweigh the risk of doing widespread PSA testing? And so as I've reiterated several times, we know now that the benefits of early detection has impact on disease progression, metastasis, and mortality rates. So by catching these things early detection does save lives. There are harms there. We don't want to act like there are not harms there. So historically, the harms in letting things go untreated. We have a lot of symptoms. Harms of some of the treatment. There's urinary issues, sexual dysfunction, potential for bowel symptoms related to surgical complications, and then just the harm of over-treatment. The good news is, and you'll see this in the next slide here, go ahead and go to the next one. We talk about, because we're doing more active surveillance here, the light blue bar there at the bottom there, over the course of the last 10 years, 10, 11 years, we're seeing a lot more active surveillance. Because we're seeing that active surveillance is now like the #1, it's the most preferred way of monitoring for prostate cancer and intervening with prostate cancer. Back when I graduated, the thing was, hey, if anybody's PSA was elevated, you send them to urology and they would get a biopsy. What we were finding was we were doing too many biopsies. Patients were having harms related to biopsies, infections, and things like that, and we weren't catching enough cancer. Now we know that there's other options, right? So are we always going through the rectal biopsies? No, there's the transperineal biopsy. They've changed up the technique to reduce complications of infection. Prostate MRI, that is something that urology is offering a lot more now, so that you can detect the clinically significant prostate cancer. Doing that MRI, you can see the lymph nodes, you can see the surrounding tissue, you can see, is this still an early stage? Is it localized to the prostate, or have we seen growth outside of the prostate? There. Focal therapy, advanced for properly selected patients. So for those patients who do require more advanced thing, the bottom line here is just to know that there are more ways of follow-up and actually screening patients that we consider at high risk. Yes, PSA testing is still recommended for number one, but once we catch things, it doesn't always mean that every man is going through a biopsy right away. Most men, based on this data, are undergoing active surveillance, prostate MRI to see if we're catching things before having to go through any kind of surgical type procedure. Next slide. And Sonia, keep me honest with my time. Sorry, I'll get rambling on some of these. But looking at this, we see our screening rates and stuff here kind of take a dip up and down here. And again, what we're seeing, long-term non-screening rates, they do kind of mirror themselves there. We see non-metastatic and metastatic prostate cancer risk. The concerning one there is that bottom right corner when we see that blue line there. This was an article that was put in the Journal of American Medical Association, seeing some increased risk of metastatic prostate cancer. This does align with what we looked at earlier in our older population there. Next slide. So this is the graph form of what we've been saying over and over again. As we see PSA screening rates go down, we see this non-screening rates go up, and we do see higher cases of metastatic, more advanced cases there. Next, some graphs and stuff there showing some county level data. This is a study that Dr. Stone was the primary author of. Just shows that over 10% proportion of men undergoing PSA screening is associated. So if we increase our PSA screening rates by 10%, so if we go from 40% of men screened to 50% of men screened, we see 14% lower incidence of distant prostate cancer and lower prostate cancer mortality. So again, this is just putting a lot of data nationwide showing where our rates are. It's no surprise if you zoom in on South Carolina on those, we see that we are bright red on those lower ones in number of cancer cases, and in the dark blue on that top one there when we look at the proportion of men screened. So again, bottom line, get our screening rates up. We're going to catch less advanced stage prostate cancer, and we're going to have less prostate cancer deaths. Next. So disparities. This is where we get into some of the racial disparities there. And I talked about it earlier, highlighted there, but the lifetime risk of dying from prostate cancer, 3.8% among Black men. So we see 3.8%, you go, oh, that's kind of low. Well, 2.3 times more likely compared to other racial ethnic groups, depending on the study and the data, is still between 2 and 4%. But the way we're going to see an overall downward trend in continued trend in prostate cancer deaths is by closing this gap here. So, looking at the top there where we see that spike in Black men, I think it peaks out around between age 65 and 69 there. If we can close that gap, we're going to see even sharper downward trend in mortalities there. Next. This is showing the same thing based on the SEER criteria, which again, the SEER criteria is looking at the spread of prostate cancer. So are we looking at more advanced cases? So Black men who have higher risk, we see at the top there, are more likely to be diagnosed with more advanced stages and everything there as we go down. We can skip ahead for the sake of time. I know I'm running, we got about 15 minutes left. So I do want to talk about some of the interventions that we're doing. Sonia, you can go to the next one there. Racial differences, more frequent, this is what I said, more frequent screening for Black men and medically underserved men will reduce that gap in prostate cancer mortality, which is what we want to do. We want to save lives, catch things early, and save lives. This is just another representation of the graph where we saw the big gap there. Next. So the SCA Men program, it's a great program. My friend Dr. Ford, who I'm not sure if she's on the call today or not, but definitely want to give a shout out to the work that they're doing through the Cancer Control Network. There shows a lot of the data that we've been talking about here in South Carolina, the differences between our white males versus our Black males there when it comes to age adjusted. So even in any of those age categories, we do still see it. And then we see that middle box there where the blue bar is higher than the red bar. That's just showing the prevalence of PSA testing within the last 2 years for men over age 40. So what we see is that white men are getting screened at higher rates, even though they have lower rates of prostate cancer, and higher screening results in what? Lower rates of deaths, right? So early detection saves lives. So one of the reasons we see lower death rates, lower mortality rates in our white males is because a higher percentage of those patients are being screened there. As a biracial male, I look at both of these and I say, hey, I've got family members on both sides, and I want to make sure that we are lower in the death rate overall, for sure. When we talk about that age-adjusted annual rate, go back one time. I just want to highlight one thing, that if we talk about the death rates there, this is also what we showed on my very first slide. One of the things I did, and we didn't put it on the slide here, but if you overlay the ethnicity demographic map here, you see that counties in South Carolina that have a higher percentage of Black males also have higher percentage of death rates there. So it goes hand in hand. We've got some targeted work to do in these communities if we're gonna close that gap. Next. So the big thing with this, and again, sticking with the SCA Men program, 3 aims: education, patient education, provider education, community education, navigation to screening. So, we can do all the screenings, or we can do all the education in the world, but if men can't get screened, if they don't have an access to screening, or if they get screened and then they can't get in to follow up with urology or with oncology, then unfortunately, we're not making a big difference. So making sure that navigation is core and central to the work that this program is doing is essential. And then doing follow-up assessment surveys to say, hey, how many men, as a result of our education programs, how many men were actually screened? How many men had a positive screening and then were scheduled for a follow-up? And that's what that data there is showing. So the 3-month follow-up, over 80% of men receive screening or schedule a screening visit, and that's great work. That shows the effectiveness of the education that's being done. So great work to our colleagues there. Next. This is when we get into the guidelines for our providers. So when we talk about healthy men starting at age 40, again, going back to the slide where we talked about the 4 different categories or that have put out recommendations, from the American Cancer Society to the U.S. Preventive Task Force, starting with Black men who are, again, considered high risk in South Carolina. We should start prostate cancer screening for Black males at age 40, or if you have a strong family history, if you're a white, Hispanic male, or other demographic. Don't want to leave anyone out here. If you have a family history, you should be screened earlier, starting in your 40s, age 40 or age 45, and starting at age 50 for more other men. So prostate cancer, the PSA, which is the blood test, a lot of my male patients are very happy when I tell them, hey, we're doing the blood test just to start. One of the things that men are hesitant to even talk about prostate cancer screening because they think they're going to get a DRE, which is the digital rectal exam. I tell my patients, I don't enjoy doing that procedure. You don't enjoy having that procedure. Let's start with the blood work, and you can always see them go, whew, okay. All right, we'll do the blood work. So it's a lot easier to get them to agree to that piece of it and stuff. So if it comes back at the PSA, or if we do the digital rectal exam and there's nothing abnormal there, we continue with the regular screening, which again, based on the previous slide, every 2 to 4 years recommended there. If it's elevated, so again, if it's above 1 for our men in their 40s, then we want to recheck it. I talked with Dr. Stone a little bit about what does recheck mean? What is, when we say recheck, okay, do I recheck in a year, 2 years, whatever? What's recommended? There's no hard and fast rule on this, but it is recommended within a few weeks. So we counsel our patients on things that could falsely elevate the PSA, bicycle riding, recent sexual activity, riding a motorcycle all weekend. I practice my clinic days on Monday. So if a gentleman, went riding his motorcycle all day on Sunday because it was a beautiful day in the low country, he comes in, his PSA is going to be falsely elevated. I bring him back in about 6 weeks. We recheck it. If it remains high, then that's when we talk about referring to urology. And so a lot of education on the importance of recheck. We know across the state, urology offices are packed. There's a backlog of referrals. And so what we're trying to do with our primary care providers, and the big point of this message, is remembering to recheck the PSA. No longer is the guidelines like it was when I got out of school. Anybody who's elevated, you automatically send them just out of, for fear of legal action. It's talking to the patient about what an elevated prostate cancer PSA means, what they need to do, have it rechecked. If it's lower, then you keep a closer eye on them, and that's where the recommendation will be to probably look at it once a year after you have a normal reading. If it stays normal, you can go back to whatever the guidelines are based on their risk factors there. The last bullet point down there for primary care providers is to see if patients are on these two medications. These two medications will falsely decrease the PSA. So if someone's on finasteride, that PSA level is 50% of its true value. So if someone comes in and they're on that medication and their PSA is at 2, you go, okay, well, maybe we need to check again in a year. Actually, that PSA is a 4, and we need to keep them, they would be considered higher risk. So that's just something that we really want to point out, and we're going to continue to educate providers about that aspect of it when it comes to our primary care teams. Next slide. So one of the great things here, and I'm wrapping up, this is my last slide of content here, that the Department of Public Health has done as a result of recommendations made by the committee that's focused on prostate cancer, is we have a website now that has a list of all the urology providers in South Carolina. There's a few that we're still confirming. I believe this is almost all verified and stuff, but it has a list of every physician group by physician in the state of South Carolina. And this is an interactive website. This is just a screenshot of it, but it shows by county where you can send people to. One of the scary things, if we overlap that map that shows where the highest rates of prostate cancer deaths, you're going to see a strong overlap with those lighter counties here, because we're seeing men who don't have access to a urologist in their neighborhood or in their county, higher rates of prostate cancer deaths. That's what we've got to do something about. So one of the recommendations and why we ask for Department of Public Health to put this website together is so if you are someone who is practicing in Hampton County as a primary care provider, where do I send my patients? You can drill in, you can do it by location. You click on that blue dot, you know exactly where to send someone. If you're in neighboring Allendale, which also has high rates, you say, oh, okay, over in Hampton County, I can get them in. It has their contact information, so we know where our referral sources are. You see that in Charleston, there's a high concentration, Richland and Columbia, and then in the Greenville-Spartanburg area, there's a lot more urologists. What do we got to do to get to these rural areas? And how can we raise awareness of where to send patients? And so this is something we're going to continue to update. It is interactive, so we'll share the link to this website. You can get on and play with it. You can click on it and it'll show the death rates. It'll show the incidence rates of prostate cancer. So if you're interested in what it looks like for your specific county, as long as we have some data on your county, it'll show there. So again, a work in progress, and a big shout out and huge kudos to my partners at Department of Public Health for the great work they've done on this website. Next, I think the next slide is just an overview of our goals and learning objectives. I know I sped through some of the statistical stuff, but I wanted to leave a few minutes for some Q&A there at the end. The last one there is, in closing, PSA screening saves lives. We know there's evidence to show that early and frequent screening for prostate cancer is going to catch things early, and we're going to saves lives. We're reducing the risk of metastatic prostate cancer, which again is the goal. And this is a great opportunity for us to educate our male patients and our providers statewide about the disparities that exist, and also the treatment and screening and follow-up options that exist when someone does have an elevated PSA. So thank you. That's the end of my presentation. I'm sorry, I can't see if there's any questions. I've been talking, so feel free if there's anything in the chat or come off mute. I'm happy to answer to the best of my ability.
I'm checking the chat right now, Dr. Poole. Are any questions?
Sure. I see something here, it looks like from Brenda Thorpe. For my efforts, I've always used county mortality rates to determine priority areas. Great. I hope that, can you talk a little bit about how I can use incidence rates and prevention efforts, or should my focus continue more? Fantastic. So Brenda, if you, when we shared that link to the website, which is public now, you can click on that and you can do mortality rates as well as incidence rates for your county, which I think that's where it's such a valuable tool, as we can drill down to look at your specific county. I hope that answers your question. If not, let me know. Any other questions or comments?
Not having any questions, Dr. Poole, but the comment thank you so much for this presentation, and really appreciate how you reiterated such the valid points, because obviously, as adults, sometimes we need to hear the information repeated over and over again for it to stick. So for someone who works in this, 100%, that was very helpful for me. So thank you so much for this. And just to remind everyone that this is going to serve as a wonderful reference for you colleagues who couldn't make it today. We will have this presentation. It is recorded, so we'll have it uploaded on our website. And when I send out a follow-up email to everyone, I'll include a link to that website, as well as the urology form survey website. I'll get there in a second, Dr. Poole, for you all to have access to. But this has been great information for providers and for patients, and just us here, DPH cancer staff as well. So thank you again. Yes, Benita said, great presentation, concur.
Feel free to share my information. Again, I will not pretend to be an expert by any means. I'm someone who grew up in South Carolina and very passionate about the public health implications of this work. So again, and if you're interested in hearing more about the work that the committee's doing, this is not an MUSC committee. So, we have representation from folks in the upstate, from Prisma, from independent urologists or primary care providers as well. So if you want information, please reach out to me. I'm happy to get you plugged in.
Thank you, Dr. Poole. I'll include your contact information in the follow-up email. And one last point is, if you would please just be reminded to complete the survey. It gives us an opportunity to grow and enhance our sessions here. So we appreciate that honest feedback. Again, Dr. Poole, can't thank you enough. I know we'll be calling on you again. So thank you again for just being part of this great experience and opportunity for all of us to learn. You all, thank you for joining us. Have a great day. As always, if you have any questions for DPH staff, you can contact us at projectecho@dph.sc.gov. But again, that information will be included in the follow-up email. And Dr. Poole, if you think of any other resources you'd like for us to share as a attachment or whatever, zip that to me, and I'll include that when I follow up with everyone. We'll let you go, but no more comments. Dr. Poole, thank you for my efforts off counting. Yes, Brenda. So yeah, thank you. Enjoy the rest of your day and be blessed. Bye-bye.
Thank you.
Hey, Sonia.
Hey, thank you all for staying on. I appreciate that. Hey.
Yes, really great information. Really great information.
Yeah. Also, one more second. Let's see.